Good afternoon, everyone. I will talk about something different, which is the role of handheld OCT in cases of RP. As we all know that RP is a common cause of blindness which affects neonates throughout the world today. And it's very challenging to examine those preterm babies in our clinic. We primarily use indirect ophthalmoscopy for examination, but previously, due to the previous limited technology and the difficulty to use the flying baby position, it was very difficult to image those babies using OCT. But now with the emergence of the portable handheld OCT, it can take us beyond the classic view of the retina and the retinal vasculature, and the information gathered by those machines can really bring new insights into the pathophysiology and the treatment of RP. We have two commercially available machines, the Optical Inviso, which is an OCT system mounted on a rolling cart. It has a lightweight handheld scanner that can be fit easily into the imager's hand and can be portable into different scenarios. And the OptiView iView, which has a handheld scanner that is used on an armature for imaging the patients in the supine position. Actually, performing handheld OCT is a science and art with many challenges that need proper training. So what is the role of handheld OCT in RP? First, we will talk about the macular edema of prematurity. Macular edema of prematurity is a frequent finding in premature infants during their first months of life. It was found to be mostly bilateral in around 60% of eyes, with higher prevalence in infants of lower gestational age and lower birth weight. And interestingly, it was found that very preterm infants who had cystoid macular edema were found to have poorer motor and language skills. It's characterized by accumulation of hyperreflective cystic spaces starting in the inner nuclear layer, and the etiology till now is not fully known. We actually don't know. It's still unclear if it's just a transient local reaction, because many cases can resolve spontaneously, or it's a pathologic event. But having observed a correlation with the stage of RP, the main factor in its development was thought to be VEGF, but others proposed that mechanical traction, other neurohumoral factors, and low density of RPE cells could have a role. This is a paper published in 2015. They tried to use the handheld OCT to investigate macular changes before and after intravitreal ranibizumab injection in cases of type 1 RP. And they found that large instances of those babies have severe cystoid macular edema that dramatically and significantly improved after 1 month of intravitreal injection. Also, the increased central foveal thickness significantly decreased after injection. Also, Vinegar et al. In 2011 divided this macular edema into two patterns. Pattern A with large dome-shaped foveal elevation, increased central foveal thickness, and large hyperreflective cystic spaces. And pattern B with multiple small confluent spaces with almost normally preserved foveal pit and moderately increased central foveal thickness. Many tried to grade macular edema into mild, moderate, and severe according to the foveal morphology and the number and shape of hyperreflective cystic spaces. Now, what about foveal development? We knew that centrifugal inner retinal layer migration and centripetal outer retinal layer growth happened in the first months of life in prematurely born infants. And compared to terms, preterm were found to have shallower foveal depression with persistent inner retinal layers and delayed development of the outer segment and inner segment of the photoreceptor layer. What about the choroid? This paper was published in the Retina in 2015. They tried to evaluate choroidal thickness in those premature infants with its relationship with the stage of RP, and they found that the subfoveal choroidal thickness was almost similar, whatever the severity of the cystoid macular edema, and it was significantly lower in premature infants. It was thinner at a higher stage of RP, and they proposed that maybe due to the oxidative stress of RPs that lead to involution of the choroid. So what about the pre-retinal tissue, or what we call the popcorn retinopathy? The international classification of RP makes note of isolated neovascular tufts on the retinal surface that were found close to the ridge in cases of stage 2 RP, as my dear colleague Sarah said, and it has been confirmed by OCT. It represents the extraretinal neovascularization and the fibrovascular isolated masses, and these lesions often coalesce into a typical stage 3 appearance. Does the handheld OCT has a role in stage 4 ROP? Yes. As shown in this paper, was published in JAMA Ophthalmology, they tried to differentiate between retinal detachment and retinoschisis in cases of stage 4 ARP. And they found that more than half of the infants with a stage 4 ARP diagnosed using indirect ophthalmoscopy had actually retinoschisis but no retinal detachment. And they put a new substage which is called stage 4A schisis by OCT. What about the plus disease? We all know who work in the RP know that diagnosis of plus disease to some extent is debatable between examiners and is subjective. And OCT can help us by specific vascular features to predict plus disease in cases of RP. And those features are put as a components of what we call the VASO score or the vascular abnormality score on OCT. And they include vessel elevation, which is defined as any spiked or elevated vessel from the inner smooth retinal surface that casts shadow over the underlying structures and make the inner retinal layers to appear ruffled rather than smooth, and that we call the scalloped retinal layers. Also, the hyporeflective vessels, which has dark lumini that cast shadow over the underlying structures, and this is different from the retinal spaces, which is hyporeflective spaces besides the elevated vessels that do not cast shadow over the underlying structures, and that represents the acute angulation of the vessels. What about the vitreous? Many papers tried to study vitreous finding by handheld OCT, and they correlated with the severity of the ROP. And the two most important criteria were vitreous bands and punctate hyperreflective vitreous opacities. Punctate hyperreflective vitreous opacities were found to be significantly correlated with the stage of ROP cases of plus and P+, and they also significantly associated with epiretinal membrane. Also, that vitreous band, whether tractional or non-tractional, were found to be significantly associated with cases of cystoid macular edema, and that may denote the tractional element in the pathophysiology of this macular edema. So what about the peripheral changes at the avascular retina, which is the main site of the pathology of RP? We have found that handheld OCT can also help us in documenting those changes, and this is a prototype investigational handheld device, which is an evolution from the bioptogen in viso. It has a large field of view, swept source OCT 6 times faster than the bioptogen, and many papers tried to use it to evaluate the peripheral changes at the avascular retina. And they have found, as shown in this photo, that we can document the progression of staging of ROP. Like here, we can see the proliferation of the popcorn retinopathy evolving from stage 2 into stage 3 up to focal vitreoretinal traction. Also, the hallmark of the ROP development in each stage can be studied using the handheld OCT. As shown here, we can see in stage 1 the line, the posterior vascular retina appear as a 3-layer structure on OCT, but the anterior avascular retina appear as a hyperreflective line that increase in thickness and hyperreflectivity in stage 2 to be ridge, with proliferation of the neovascular tufts and inner retinal layers splitting with increasing thickness of this hyperreflective band in stage 3 up to focal vitreoretinal traction and tractional retinal detachment in stage 4. Finally, we will talk about handheld OCT angiography. It has a role in cases of RP. OCT angiography is a non-invasive dyeless and depth-resolved technique to study the superficial and deep capillary plexus, and it overcomes the invasive nature of fundus fluorescein angiography. And the main limitation in those babies is the requirement of a steady and precise fixation, which is actually a challenge in those younger children. Many studies tried to evaluate the morphology of the microvasculature and the abnormalities in those preterm babies, and they have found, as shown in this photo, for example, in cases of aggressive posterior ROP, we can document the flat new vessels that is not evident just in the superficial capillary plexus as we thought, but also it extending into the deep and the outer retinal capillary plexus, and those changes dramatically improved after laser treatment. Also, they have found that the FAZ and the vessel density in cases of type 1 and type 2 ROP were significantly lower than controls either in the superficial capillary plexus or deep capillary plexus with the presence of aberrant vessels in the fovea. So in conclusion, handheld OCT can help identifying early in the development of ROP eyes at greatest risk for lower visual acuity or other poor outcomes that allow for better and potentially new therapies for the disease. It's an exciting present and a promising future for understanding mechanisms leading to different outcomes from ROP. And I just like to say that there is an ongoing study now by Dr. Rawan Hosni in the ROP service, and she used the handheld OptiView to document the macular changes in type 1 ROP before and after intravitreal injection, and waiting for her nice results, inshallah. Thank you very much.